Welcome to the Ambulance Medical Necessity webinar. This webinar is designed to cover when Medicare will consider an ambulance transport medically necessary and why we'll cover them. It will also provide some of the documentation details that you will need. I'm Tom Ryan with Provider Outreach and Education. I'll be your presenter today. Today, I'm joined by Ellen Berra, and she is from my team. She's also one of my friends, and what she's going to do is help with that chat. Now, we'll let you know that as time permits, I may take questions in the chat, but you will want to place them in the chat. If I don't get to them, I will answer them later. This is a recorded event. If you object to attending a recorded event, please make sure that you disconnect at this time. Couple more housekeeping things. If you want the presentation, please go to our learning center, our training center, sorry, and download it. It's on the live events page. It's currently available. It will be available till the end of the day today. Then what will happen is we're going to record this presentation, and as it's being recorded, we will then give you a copy as part of the Encore package. Now, the Encore package will be posted to our Encore page, same training center, just another page. And inside there, you'll have the opportunity to download the presentation for 60 to 90 days. After that, the Encore will remain on our YouTube channel until the information is no longer relevant. Again, if you do have questions, put them in chat. I will get to them as time permits. And if I don't get to them, we will do a mass email out to everyone. After this event, you will be given the opportunity to complete a survey. I've asked Ellen to put the survey in the chat. You can watch that link or keep it for later, whatever you want to do. I'm going to give it to you many times throughout the event. My goal is to get you guys to complete the survey and give me the feedback that I need. What do I need? Well, I need to know the good, the bad, and the ugly. What did I do well? What did I not do well? And did you like my PowerPoint presentation? Did my resources help you? And what do you want to do for future education? So we're going to get all that later on the survey. Couple more things I do have to do. One of the things, I did check the information. The information is as current as I can possibly get it. By that I mean, we look at it, we try to make sure it's current, but changes do happen within CMS, within the federal government, and the federal laws even. So we want to make sure that you're always checking that information that will be available on the CMS website. I also wanted to let you know, I did review all the questions and the answers. And I'm going to give you the answer based on the question that was presented. Now, that may seem like something that I shouldn't have to say, and some people have actually commented on that, but I want to let you know that a little bit of extra detail or a little bit of extra information left in or taken out can definitely change an answer that we would give, especially when we're talking about medical necessity for ambulance. The more detail we have, the better we can clarify the answer, but sometimes that detail will also change to say, yep, we believe that would be medically necessary, or no, we would not. Also, remember, answers given during this are not based in documentation. We don't have the documentation in front of us. And without seeing that documentation and doing a review of that, we are unable to answer specific questions. Just like with claim, I don't have a claim in front of me and I can't look it up. Therefore, you must contact customer service for that help. So the answers will be based on what I have in front of me and what you're able to describe. All right, here's our agenda. So what are we going to do today? We want to look at some of the requirements for showing an ambulance transport is medically necessary. What makes it medically necessary and why will Medicare consider it? Now, keep in mind, this is a very specific section of the Social Security Act that talks about this, so we'll go over that a little bit too. In order to do that, the first thing we'll talk about is the assessment information, the importance of assessment, the importance of what an emergency medical technician EMT assessment has to have within it, and why we use that. We had a lot of questions on the physician certification statement. I was not surprised by this. So we did build in quite a bit of information on that, and hopefully I'll get to every question and answer it in a way that you will understand and be able to utilize. But I do want to remind you, questions can go back in the chat. Last, we actually had some scenarios that were submitted between this one and another webinar that we did a while ago on ambulance. A while ago, it's about 3 months now. And we're using those to create some questions and scenarios that hopefully will help you understand medical necessity. Now, keep in mind, if you have more specifics or you want something more, you are more than welcome to post into chat. The first question before I even leave this agenda is there anything new this year or for next year for ambulance medical necessity? And the answer is no. Nothing's changed. We are continuing to receive these questions. We are continuing to receive this type of scenario question and what is going on, which is why we're conducting the education. But again, I wanted to make that very clear right away. All right, let's start with a little bit of background. First, this section is designed to provide a kind of benefit overview, but also some general understanding. To let everyone know, we did have some very basic questions like information that just basically said, hey, what would make an ambulance run medically necessary? Well, in order to do that, I've got to provide a little bit of background. Someone asked, is there a certain time Medicare would or would not pay for an ambulance transport? Again, without this background and this little bit of information, we can't really answer those questions and we can't move forward into some of the other stuff. So I don't want to leave anyone behind. So for some of you, this may be a bit of a review, but for others, this is going to be very key and important. I want to let you know that I did receive a variety of questions. The questions are regarding Medicare Advantage plans, MA plan, Medicare Managed Care plans, all of those types of plans. Now, some of them were regarding prior authorization for those plans. Keep in mind that is not traditional fee-for-service Part A and B Medicare. That is Part C. Our prior authorization is a different process, and it's actually only used for routine scheduled non-emergency ambulance transports, RASNAT. If it's for any other reason that you're required to get a prior authorization, that patient probably has a Part C plan. Now, we cannot talk specifics about any style or set of Part C plan information because each plan is unique in and of themselves with the private insurance company that contracts with Medicare for that plan. So again, any answers I give during this presentation are based in traditional fee-for-service Medicare, Part A and B, and they are also for Jurisdiction 5, Iowa, Kansas, Missouri, Nebraska, and the national contract, or Jurisdiction 8, Indiana and Michigan providers. Let's talk a little bit about the next one. The next question that was asked, sorry guys, didn't mean to flip that far, is how does this affect mileage? How does this all affect together when we talk about a denial? Where does it come from? And that's a series of questions that I kind of combined into one, so hopefully I'll get through that. So first, our medical review department is currently looking at ambulance claims for routine scheduled non-emergent ambulance transports. That's RASNAT, and they do a prior authorization process with that one. And that one's going to be based on the physician certification statement. Now, they also have a targeted probe and educate on the Advanced Life Support ALS code A0427. Both of these are complex medical reviews. This means that someone who's a registered nurse will sit down and actually look at the information set in to determine whether or not that transport can even be considered for medical necessity. Now, RASNAT, again, is a prior authorization, is done even before the transport occurs, where the TPE process is not. TPE is done after the transport occurs, but on submission. So it's a little bit of a different action there. However, they both do result in the number one finding that we've heard back from them, and that is that the run, report, and assessment do not support the medical necessity. So in other words, when they're looking at the run report, plus the EMT assessment, they cannot find a medically necessary reason for transport. This means that this violates the Social Security Act, Section 1861 S7, which states that the transport cannot be contraindicated. In other words, there's no other safe way for that patient to go. So when you bill something that's not medically necessary, that's what we're looking for. Now keep in mind, a medical necessity denial for that reason can be appealable, especially if it's gone through medical review and you want someone else to review it. That's perfectly okay. That was put in based on the question that asked, what rights do we have if we disagree with your medical review finding? So again, that one is appealable and you would go through that. Okay, the second action is something that some people will do, but it's not done as often. And the reason is that the mileage doesn't match. And so therefore there's a down-quoted mileage. Now, again, it's not done as often, but yes, we do look at the mileage charge. So if your base rate isn't medically necessary, mileage will become not medically necessary. Well, that makes sense because you didn't have a medically necessary transport. On the other hand, can mileage be down-coded? And the answer is yes. If you're going a certain distance outside of a locality or a normal patient distance where they would typically get care, that can cause a down quote on mileage. Again, that's the second reason that we would look for. Also keep in mind with that one, it is also appealable. If you disagree and you say, no, this was the closest facility, no, this was the only one that could treat them, whatever the situation is, that would also be appealable. So when we look at the medical review denials and why are we doing this education, that's where this information is coming from, is those two big denials. The big one, again, medical necessity. Question that we got is, other than WPS, are there review entities that do look at ambulance? And the answer is absolutely. We put this one in because every medical review entity is going to look at medical necessity for ambulance. If they're reviewing it for any reason, medical necessity will come up. What we typically see is a report tells us the results. And the results state that they're finding things not medically necessary. So we really wanted you guys to understand that yes, there's more than WPS, and no, we are not alone. Couple of them are outside of the contractor realm, and an example of that would be the Office of Inspector General. They're another area under the Department of Health and Human Services. They are at the same level as the Center for Medicare and Medicaid Services. They're part of the Medicare review program, and they're checking for fraud, abuse prevention. They're checking for compliance errors. They're checking for all of those kinds of things that, you know, to save the Medicare trust fund money. I've also heard them referred to as DHHS, or Department of Health and Human Services legal watchdog. It's a nice way of putting it. They're really just trying to make sure that we get everything done in a compliant manner. They're watching for all of that different stuff. Now, again, we as your Medicare administrative contractor absolutely do. We look at different targeted probe and educate. And right now in particular, I believe the only one we're still looking at is advanced life support, but we determine those based on data. So the data could drive to something else. Okay. Who else looks? And this is where I think some of the questions came in a bit more. The recovery audit contractor absolutely will look. Now, for those of you that don't know and are not familiar with this program, these are post-pay reviews, and the recovery audit contractor is under the recovery audits program. The contractor themselves proposes to CMS what they're going to review. CMS must approve the proposal list. And so what they've done in this case, and you can see I gave you a link just onto those approved topics, the recovery audit contractor said, hey, we're going to look at advanced life support, medical necessity, and documentation. We're going to look at specialty care transport and air. Basically, what they're looking at is advanced and basic, specialty, and air. Well, isn't that every ambulance transport that they potentially could look for? And when they say medical necessity and documentation requirements, that's what we're going to cover today. Because they will look not only at medical necessity, but to make sure the documentation is signed, dated, the basic documentation requirements. Now, I will tell you that if you look at the dates on the audits, which is going to be in the far right side, the last column, you'll see that one of them started in 19, 20, and 21, respective year-wise. Please note that if they continue to find errors, they may add more for different reasons. And these are not the only ambulance that are on this RAC approved list. So if you want to check out more, we do recommend that you actually go to the list itself and look it up. But these are just the three that we wanted to highlight because they do talk about medical necessity and ambulance documentation. The next contractor I had a question on, and someone asked what the goal of the CERT contractor is, or what do they do? And the actual answer to that is the CERT contractor creates a paid claims error rate. It's a national paid claims error rate. So their goal is to look at a claim that was paid or not paid. For instance, it will apply to deductible. Their goal is to see if we process it correctly. We being your Medicare administrative contractor. Now, it's not just WPS, it's any Medicare administrative contractor. So anyone can go ahead and do that, right? What'll happen is they're not going to just say, oh, we just want to get 100 claims in, and we're only going to focus on ambulance. It's actually going to be a little bit the opposite there. What they'll do is random sampling. These are the claims that were processed. This is what we're going to go with. Okay. So we want to make sure that all of that is aware of what's going on. So that is the paid claim error rate, which comes from the Comprehensive Error Rate Testing Contractor, or the CERT program. If you have more questions on the CERT, please feel free to put that into the chat. I do know that I did have a couple of questions, and I think I got it all. I want to make sure I did. Before I leave this one, I did have a question, and I did not know that anyone would ask about this particular contractor, so I'll address it here and then we'll move on. And the contractor is, what is the UPIC? And the UPIC is the Unified Program Integrity Contractor. And this contractor's goal is to investigate suspected fraud, waste, and abuse in the Medicare and Medicaid program. So the UPIC itself is someone that gets referred to an investigation for a fraud, waste, and abuse. It's not something that you typically will be put into, or that you're just going to randomly be assigned to. We have to have a reason to refer you. And it could be, you know, from a patient complaining against you. It could be from another provider complaining against you, someone within your own organization. Any of those are possible. But their job is to make sure that you're billing correctly and to make sure that you aren't fraudulently billing for something. Okay. And also, one of the things with some of those different programs when we look at medical review is, remember, there's quality program medical reviews, which don't have anything to do with nearest appropriate facility. It's patient care. The patient goes to that quality review. They have to have a quality review to say, hey, this is outside of the realm of, you know, whatever. I don't agree. I don't like how this hospital treats us. That's not something that we're going to do from medical necessity. Okay. And so that then affects your ambulance reviews well, because that's a separate quality type review. So there's, you know, some different questions that came in about different types of things that can affect ambulance medical necessity. And it could be a perfectly necessary run, but we're saying, why are you leaving that facility? Because that's also a portion of it. When we look at ambulance medical necessity, why did you leave that facility? And that would go for like any kind of hospital to hospital, ER to hospital, etc. Those types of transports. So, all right. So with hopefully out of the way, and hopefully I got enough information, but again, if I missed anything, please put that back into chat. We're going to move on to the assessment. And Ellen, would you mind just checking to see if we have any questions before I hit the assessment?
We do have one question, Tom, and this is from Rachel. And her question is, what if there's a local hospital, but the patient refuses to go there because the care there is horrible? Patient's opinion. How would that work?
Sure. So I'm going to address this in a couple of different manners. First, the patient's refusal to go would be considered patient preference. So you can take them to whatever hospital they want to go to, but the patient may be responsible for a portion of that bill. And if they're going to that hospital, wherever it is, and it's X amount of miles away, but this one would have been able to treat them. Now, if the patient says, I don't want to be responsible for that, you're still going to bill it accordingly. You can still bill the transport at whatever level it occurred at, ALS 1, ALS 2, you know, BLS, whatever, doesn't matter. Bill that accordingly. Then for mileage wise, you can do a couple of different things. One, bill, especially if it's ground, A0425 and A088. The 425 is what you would say, okay, this is our payable mileage. Now the patient wants to go here, we're gonna bill it as an A0888. What you're doing is telling Medicare, this is what we would consider non-covered mileage. It's the patient's preference mileage. Inside your documentation, please make sure that you document accordingly, whether it's through the assessment that you came up with that information, whether it's through a conversation, whether it's at dispatch, doesn't matter to me where it is, but it has to be there. Once we get that, we will deny the A0888 as patient responsibility. You have no further action. You didn't feel it was not medically necessary. If the patient wants to take it to the next step and they want Medicare to consider that, then they need to file an appeal. They need to tell us why on, I think you used the word terrible or something, bad, whatever it was. They need to tell us why they didn't want to go there, what it is. And that appeal will then go through the steps of appeal. And there are 5 levels. So hopefully that answers the question. If not, Rachel, put some more information back into the chat for me. Ellen, anything else?
No, sir, that's all we have at this time.
Thank you. All right. Well, let's go on to the big driving factor here. It's the assessment. Now, this is the emergency medical technician assessment. This does not matter which level they're at. So, you know, some people say to me, hey, my state says an EMT is only EMT basic, intermediate level. They don't necessarily use that term, but a paramedic isn't an EMT. Now, for Medicare, I want to remind you that an EMT is a basic, intermediate, paramedic. All of them will fall under the category of an emergency medical technician. So starting with your basic key point here, does Medicare look at the EMT assessment? Yes. Can an assessment be done by anyone? I'm not sure what you wanted with this particular question, but let me address it in this way. And if not, put it back into the chat. An EMT assessment must be done by someone who is state licensed at the level that is needed for that patient's care. So depending on what's going on with that patient, the assessment may need to be at a paramedic level. It could be at a lower level, ALS or ALS, but what we're really looking for is what's going on with that patient. Does that assessment alone drive payment? It can at an EMT, at an ALS level, ALS 1 level, but ALS level 2 is, it is what it is. It's an ALS level 2. There's not two codes for it. Same thing with BLS. So yes, the assessment can move you from a BLS. You can do a BLS service, but the assessment alone needing to be done at an ALS level can make it an ALS payment. But you want to make sure that you documented that very clearly. So hopefully that answers that first question. The next one is, what are our requirements? And we actually did have a couple of different ways that this was put in, so I want to make sure I'm going to get all of this information for you. There's a very simple answer to this, and this slide provides it. Must show the need for the emergency medical technician during the transport. Sounds great, perfectly simple. That's all I got to do with my assessment. Here's what we have to do. When we look at the need, we are looking at, one, what is the required level of care? Why do they need a paramedic versus an EMT basic? Why do they need one of those two different levels of EMT? What kind of care, what kind of conditions do you know about? Two, why is their medical skills needed? Now, this would also mean, why are they actively monitoring a patient? So if I don't need a medical skill, could I do active monitoring? Yes, Medicare does pay for active monitoring. I want you to circle the word active. I've said it a lot and I'm going to keep saying it because you have to tell us why you need to monitor that patient. One of the pieces of information I got in from one of our medical review nurses simply said, the patient's on oxygen. That was the active monitoring they were doing. Well, that doesn't help us. There are people that walk around every day with oxygen tanks. Who's actively monitoring that oxygen tank to make sure they're getting the required level, to make sure that they stop and take a break when they need to do any of that? That's them. So just because they're on oxygen does not make an ambulance transport medically necessary. Also, just because that oxygen tank is not available, it doesn't mean that it's medically necessary. There are other things they could do. So we have to look at why that patient could not safely go by a different means. Also, when we look at local protocol and state protocol, it doesn't make it medically necessary. One of the ones that came up, and that was a really good situation of this, was they were doing active monitoring for COVID. Well, the patient had signs and no symptoms of COVID, was actually transported to the hospital, arrived at the hospital. Now we say hospital because it was an outpatient department at a hospital. They were not in the ER, it was an urgent care outpatient department. And okay, she was with her husband. Her husband drove her, has already been exposed and all of that. And then they said, ooh, we need to get you moved. And we don't have a bed for you because you have COVID. We need to put you, inpatient, monitor this and track this. Well, the response was, we wanted to move her by ambulance. And Medicare's response was, why is that medically necessary? The husband's already been exposed. If he's going to get it, it is what it is, right? What were you trying to do, and what was the active monitoring or the isolation that was needed? This is different than a patient who actually arrived, went to the ER, couldn't breathe. The ER did not, was a freestanding ER. It was owned by a hospital, so it's an off-campus department, and the patient needed to be moved to the hospital. So great, we got them stabilized and treated within the documentation. That's what the ER documentation shows. Then the ambulance picked them up. They had to keep this person stable. Their breathing was sporadic, intermittent. They were having trouble holding oxygen levels up. There was a constant need for monitoring during that time so the patient maintained their oxygen level. Also, because they had an AFib situation, they didn't want to push them into that any further with the cardiac incident and having COVID. So there's a lot going on with that one, right? So the more information we have, the better we can process the claim and judge that medical necessity. So that's what we're all looking about. So just remember, just because a state or a local protocol says it has to be done this way, it does not make it medically necessary for Medicare. We really are looking for those medical skills. So when we say medical skills, I've asked a couple of questions in a couple of different times, and I do have a couple of our clinicians on. So if any of them, after I present this, I'll give them just a chance to see if any one of them wants to say anything. But what are we looking for when we start with our basic assessment? First, keep in mind, we have to start the patient complaint. We're looking for, why were you sent to the scene today? Or why did you stop? Patients on the side of the road, you stopped, you saw someone sitting there. There's still something going on. Did you go try to talk to them? Were they able to talk to you? Were they incoherent? What's the complaint? What's going on? What's happening? Then you're going to move to your basics. What did you see? What did you hear? What did you smell? And what did you feel? See, most people get this one pretty easily. And that's, hey, I see dislocation, or I see discoloration around an arm or something like that. So it's, what did you visually see? Now, someone said, why do I have sizes in here? And my answer to you is, what if you see swelling, or you see lack of, and you see an extension that shouldn't be there? This leg looks longer than the other one. What's going on with it? Okay. What did you hear? Now, think about breathing with this one. Did you hear, what type of breathing did they have? Was it normal? Was it labored? Describe for us, was it labored? Did you hear a wheezing or something that may indicate that there is blood or something else going on? Did you see bubbling and gurgling with that breath? So you saw and heard something together. All of that helps to build. Next one, smell. Anyone who's ever dealt with this knows that there's distinct smells that you want to instantly be aware of. I was a social worker. I had a patient or a person come to me, and he had gangrene. Now, I didn't know he had gangrene. It was my first time experiencing that. But let me tell you, after experiencing it, I now recognize that smell. Again, didn't keep himself super clean again, which led to the gangrene and other things like that. So there are certain smells. What are more common ones that you're going to have? Definitely alcohol, definitely other drugs. This can affect even your treatment, because with certain things, the blood may be thinner, or there may be other abuse or actions that come with those types of drugs. So what did you smell, and how did you react to that, and what caused you to do certain things? Last is the feel. As you're touching the patient, you're checking the patient, you're trying to do different things. What did you feel? Do they have a hard abdomen? Are you feeling for a vein and you cannot find one? Again, that could be related also in part to smelling them using a variety of drugs or other things, just depending on what's going on, right? When you were feeling around, what was going on with their body? That's your basic components. You want to make sure that we understand the patient's state at that moment, what's going on right now. So I do want to answer one question, then I'll see if if any of the clinicians have anything to offer. But the question is, does this have to come from the patient themselves? The answer is no, it does not. When you're beginning your assessment, think about it. What happens if you arrive and a patient's sprawled out on the floor and their husband or wife is like, they just fell down, they're not getting up, I can't wake them up? What are you using to take that complaint? What are you using to gather that information? You're still going to do the see, hear, feel, smell, all of those, but you're also going to use bystander and family information. You're going to take anything you can into account to treat this patient the best you can. But that also then needs to be translated into the documentation. How do we know what you know if you don't tell us? That's the basic gist of what Medicare is going to ask with that one. Before I leave this slide again, I just want to throw it out there, and they may not have anything, but does any of the clinicians or anyone else have any comments on assessment?
Hi, Tom. It's Mary Sue. I do not. You did a great job. Thank you.
Thanks, Mary Sue. So for you that don't know, that's one of the clinicians from Poe, and I just wanted to make sure she was good. Next, okay, this one's going to be really basic, but I still have to put it in here because you guys did ask a couple of questions on there. First, date. I'm going to tell you that I gave you a reference for this one, and it's a signature and date book. It seems very basic, but it is one of the things that we still are having issues with today. It's getting the valid signatures. So a signature, in order to be valid, one, it has to be the person who's assessing the patient. Well, that makes sense. The assessment has to be signed. If a different person, literally physical person, treats them, which means does the in-care or rig work while they're being transported, that person would also need to sign. It's a different person. But along with that, the patient needs to always sign. This was the question, and does the signature for the patient have to occur before the transport? And the answer is no. What Medicare states is it has to occur before billing the transport, because part of that signature is to gather the fact that you can bill it. Okay. Now they do go on a little bit further into some other information, which will help you out with that. And there's some ambulance signature stuff, and we'll talk a little bit more about that. But do I need to have a signature with the credentials and date for any professional? And the answer is yes. And this would include the EMTs, but also the receiving or discharging facilities. So where are they leaving or coming to? We want to know who they are, who told you, who gave you what information. It's very important. One of the questions that we got regarding this, again, comes back to, Medicare Advantage plans and Medicare traditional fee-for-service, I'm assuming, have different requirements for the driver to sign. I can only talk about traditional Medicare, which is that fee-for-service, that Part A and B Medicare, and we do not require the driver's signature. We do require that the driver have a valid driver's license. However, that's not ever checked by us because we're looking for medical necessity. That would be checked different contractor looking for potential abuse or looking for something else that's going on. We don't check for that. So the next question came up and said, well, what do we do if the patient can't sign? Because, right, we need their signature along with the professional signature. One, there's a whole set of criteria out there that Medicare has on their website and CMS, and it's the beneficiary signature criteria. In general, however, if the patient can't sign, first, tell us why they can't sign. Tell us. If you say, well, the patient refused to sign, that's different than I cannot sign. It's not the same thing. A refusal to sign means they're refusing to allow you to bill it, so therefore they're going to be responsible for it. Now, if you say the patient's passed out laying on the road, they obviously can't sign, so I had this person sign on their behalf, and that may be the receiving facility or, a variety of other criteria that went into that. That's fine. That's when the patient just literally cannot sign. You could also say, hey, we tried to get it, the patient's not responding to us, and here's how we do that. All of those are valid options. So if you want more information on that, check out the Ambulance Services Center on the CMS website, and we'll get you that information. It's a beneficiary signature information. Next question that came in, and this is obviously someone that provides air transport, and they're asking, is there additional criteria for air versus ground? So I've given you some basics. Hey, why isn't medically necessary? Why is all of these things? What is the EMT seeing? What is that assessment proving? But what else needs to go into air? And your key with this one is to determine why the air is the only safe means of transport versus ground. Now, this is not just, yep, someone said go by air. Well, that's great, but why is it today the only means of transport? So we have to look for what is going on during that assessment, again, during that assessment that shows air is needed. So what are we looking for? One, distance and time. Distance and time. Why will it be shorter or safer for the patient to go by air versus ground? If you said to me, I'm going to put this patient and we're going to do a fixed wing transport, and by the way, that fixed wing is going to be 45 minutes away, then we're going to have to transport the patient from where they're at to the airstrip. Once they're there, they're going to fly, take taxi, fly, taxi, land, retransport to the next facility. It's very common for a fixed wing. And all of that whole process is going to take 2.5 hours by the time in total. I could have transported, literally driven them within 90 minutes. So we're going to say which one was best for the patient. That's the question we're going to ask. Now, your job is to support within the documentation why the air was the best means and the safest means. So it's not just one or the other in this case. And I'm making that as clear as possible. What else are we looking for? Are there things going on that make it impossible? Like by things I mean rain. So in certain areas, it seems like it shouldn't be that long until you find out that there's a flood, until you find out that there's this. So if we were to look at a map, we'd be like, oh no, you can get there. And find out, wait, those roads are flooded, and now it's going to take you an extra 2 hours to get around that. So it's actually going to be easier for me to order an air transport and have them lifted. Those are the types of things that we don't always know. We're not always aware of what's going on in every area of the country at all times, so that when we look at air versus ground, that's what we're looking for. Why are you doing what you're doing today? Along with that, someone said, well, what if it's just simply ordered by the hospitalist and the hospitalist says take them by air, and you get there and you're trying to struggle with it? Okay, that is when it isn't medically necessary for the air, but it could be for the ground. Not for the air, but could be for the ground. If the patient's stable, you can give an advanced beneficiary notice of non-coverage. This is a form, it's the CMS R131 that indicates this portion of it will be your cost if you choose to go by air. Okay, so please be aware of that. And hopefully that answers those questions. If not, put some more back in chat for me. All right. Oops, sorry, before I go on, Ellen, I just wanted to see, did we have anything submitted in chat for questions wise? Are we still good to go?
We don't have any additional questions at this time.
Nice. Okay, we'll keep going. I want to talk about the physician certification statement, or PCS, next. The question is, what is the importance of the PCS when it's not always taken into account for the medical necessity of the transport requested by the physician? First of all, I want to address that. No PCS alone will prove medical necessity. As I continue to state throughout this whole thing, your assessment, then the treatment, then what's going on will prove medical necessity. One, we've all seen PCSs that were written and you get there and they completely contraindicate, or they're not even the same as what's going on with that patient. Also, for some PCSs, they're written 60 to 90 days in advance. Well, how does that, 45 to 60 days in advance is what I meant to say there. It's 45 to 60. How does that then indicate what you're seeing today? Okay, so we want to make sure that we're aware of that. Who's responsible? It is the EMT's responsibility to document the medical necessity, and whoever is getting paid for that, the supplier or the facility that is getting paid for that transport, is responsible, which is why the physician certification statement is taken into account. We do look at it. However, it does not alone prove medical necessity. So let's move on to the next question and say, well, what all this stuff and what is it and why is it important? Well, number one, a physician certification statement, sometimes referred to as an ambulance order, is what it is what the item is. What it does is it's a written statement by a medical professional. So this could be a physician practitioner, such as a PA or a doctor, examples. Their reason for the transport and for why they want this patient transport is put onto a written form, and it tells what helps to address what the EMT should assess. It's what's really the goal is. Take what they want and say, okay, why are we transporting them? What are we doing with this? Now, keep in mind, they're not always required, but it doesn't prove medical necessity either. Someone asked very specifically, when is it required? And the key thing that's required for a routine scheduled transport. So that, in other words, it's scheduled 24 hours in advance. It's going to be a certain number of times per week, and it's going to be a certain transport. Dialysis, chemo, these are scheduled routine transports in which a PCS would be required. Now, someone said, isn't it required for a hospital to hospital transport? And the answer is, I don't have enough information just based on that alone, but I'm going to answer it as best I can. Some hospital to hospital are called one-time transports or non-scheduled, which means they weren't scheduled 24 hours in advance, or they're only going to occur once. In this case, yes, you can get a physician certification statement. You can also have a non-physician certification statement, which can be the exact same statement. It's just who signed it. But the intent of the transport, is it routine and scheduled, will drive whether or not it is required. So we do have an or situation and we do have an absolute situation. So on a routine scheduled without the PCS, you will not get paid. Next question came in was, do all transports need PCSs? And the answer is absolutely not. First of all, if they're not under the care of the physician, who's certifying this care? I mean, really stop and think about it. If you're picking them up at the home and they don't have a certain condition, Who's certifying it? What are they doing with it? That's not going to be useful. They're in a car accident. Where are you getting the physician certification from? So they're not under the care of the physician at that time. Okay, then we're going to say, are they under the care of the physician? Well, what could help you indicate that they're under the care of the physician? Are they in a nursing home? Now, in that nursing home, are they in a skilled nursing facility section? Because just because you're in a nursing home, this may be your normal area to live and you may not be under any care of a physician. It might just be literally a nursing home. Are they in a residential care facility? Are they under the care of someone else, such as a private residence, but they have a home health nurse coming in? Then they're still going to be under the care of a physician. That home health nurses has to have a certified plan of care, which means a physician at it. Are they in a facility? Now, by that we mean, are they under observation or are they inpatient in a facility? If they are, then yes, they're going to be under the care of a physician. And then things like site of an accident. Well, probably not under the care of a physician, right? You can't anticipate a car accident, so we don't expect to see that. So when we look at this is all something that needs to be determined as part of the assessment. Where did you pick them up at? What are you doing with that? It then drives the medical necessity to make sure you do or do not need a physician certification statement. Hopefully that answers those questions. The next question that came in is, what is it needed and does it have to be a certain form? And the answer is CMS does not require a certain form. CMS actually, in the Code of Federal Regulations, and at section 41040, 42 CFR section 41040, defines this. And they use instructions to say that you can make your own up as the supplier. As a matter of fact, they don't even tell you it has to be called a physician certification statement. Instead, they say, call it what you will. So if you're not familiar with that, we do recommend to go ahead and take a look at that. And you can just simply search 42 space CFR section 410.40, Google it, use any of those search engines and it'll pull up for you. So it does not need to be standalone and it does not need a specific format. So the question that we got in was, would a encounter note from a physician count as a physician certification statement? Well, the CFR very specifically states it does not need to be a standalone document. So could it count? Yes. The problem with that, or the thing you need to be aware of, is it still has to contain the pieces of information, right? It has to be able to identify the patient by name and by identifying information. It has to be able to identify why the physician or non-physician feels this transport is medically necessary, not just weakness. It has to be able to explain that information clearly and identify it clearly. It has to have medically professionals' date and credentials. Now, commonly this will be there anyway, right? And everyone understands this one's going to be there. It's going to be there because if the medical professional wants to get paid for their service, we got to have a date and professional. But then it also has to have some transport information. What type of facility do they want them to go to? Why are they moving them in the first place? What's going on? Give me some basic type of transport information. So if the note comes in and says, hey, we feel like this should go by ambulance because there's no wheelchair van available. By the way, we have seen that. That's not going to be medically necessary. That's indicating they could have gone by wheelchair van had one been available. So when we look at that medical documentation, even if it is an office visit, yes, we can consider it. However, may not be the best form to use. All right. Next, I'd just like to move on and talk about a sample form. And this sample form was created with provider outreach education in conjunction with our medical review department. What we did is we looked at all situations in which a physician certification statement may need to be required. We then put as much information onto this sample form. It's 2 pages long, but it is a sample. It is something you can use and you are not required to use. Remember, you're required to develop whatever form you want. However, if you do not have certain pieces of information, the form will not work and it will be considered valid, which is the #1 reason that we are getting denials or non-affirmations for those routine scheduled ambulance transports. So you want to make sure that you have everything you need within it. So it is designed again for any situation, and it will gather all medically necessary information. This is available on our website. For those of you that are not familiar with this, and I'm going to take just a moment to show you where it's at. Ellen, can you verify that our website did come up?
Yes, sir, it did.
All right, perfect. So you can come into the topic center. Now this again, it's just wpsgha.com. You can go topic center, and then you're going to go to documentation. Now, documentation is the area that we're talking about. This is a piece of documentation. When you get to documentation, directly under the top navigation areas where you'll have the login, you will see the word forms. It's going to be on your right side on that little gray bar. Once you go ahead and select forms, scroll down and you can look at any of the different forms. The last one on the right column in the body will be the physician certification statement. I'm not going to download it. You guys do have a sample of that on the slide. This is where you're going to find that. And the reason that I wanted you guys to see that is you do not have to use it, but a lot of people have asked if they could model their own after it. And absolutely, that's what we created it for. So if you're interested, take a look at it, see what's there. All right. Next, going back to the slideshow, the Code of Federal Regulations, and you guys did hear me reference just a minute ago, the Code of Federal Regulations help specify when you need a PCS and when you don't need a PCS and when there are other exceptions. So again, the special rules for non-emergency scheduled repetitive services say you absolutely have to have one, no PCS, no payment. The second one does say, okay, if you have a non-emergency or a one-time scheduled and you don't have a PCS, here are the steps that you must follow in order to get paid. One of the questions that came in is, what is a scheduled transport? And for the purposes of these definitions, it is scheduled 24 hours or more in advance. A lot of providers say, well, I just want to use the day before. That's fine too, as long as it's in that time frame. Next question, when the sending hospital that orders the ambulance has different information listed on the PCS versus when the crew arrives, is the sending hospital held more responsible for this misleading information? And we talked a little bit about this, but to address this more fully, remember, the person getting paid is ultimately responsible. That is the ambulance supplier. That's why the PCS helps inform, but does not support the medical necessity. We want to make sure we're well aware of that. Ellen, any questions before I move into the last section?
We don't have any additional questions yet.
All right, perfect. Okay, so scenario one, what I did is took and summarized the run reports, the dispatch reports, kind of put them all into scenarios for you guys. I thought it might be easier than just trying to get through everything. So this one was a 911 call reporting a heart attack. The EMT assessment shows the patient is short on breath, complains of arm and chest pain, as the skin is pale and clammy. Record includes a run report with assessment, EMT signature, and receiving facility signature. Notice the next bullet, no patient signature on the record. The appeal is filed for medical necessity. Now again, this came from our appeals department. What are we looking for and why didn't this one happen? Well, why wasn't this one overturned? First, it's not a medical necessity denial. This was denied for no patient signature. So we're not saying it wasn't medically necessary. We're saying, hey, this one, give me a patient signature. Now, not only was there no patient signature, there was no rationale for why there was no patient signature, because this is a situation where they might have been able to get it had they followed the directions and been able to do that. So we want to make sure that you are well aware of that. What I had asked Ellen to do with this scenario is to give you guys that signature guidelines. Now, had this one said, patient's unable to sign blah, 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 and we got da, 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 that's what those signature guidelines are going to spell out for you. So make sure you follow the signature guidelines. But in this case, it didn't have anything in it. So therefore, we upheld the decision on appeal, and the denial was not overturned. All right, so scenario two, why didn't we review this one for medical necessity? That's the question we're going to answer. The patient required transports to an MRI. Okay. Scheduled 1 week in advance, so we know it's scheduled. Patient is inpatient in a skilled nursing facility. Okay. PCS signed by a registered nurse treating the patient daily. Patient and EMT signature are on the run report. What do you guys think about this one? Well, in this case, when we looked at it, we were like, well, why couldn't the primary have signed? I mean, they had a week to get it. You showed no reason that you didn't even attempt to get it. So why couldn't the primary have signed? Now, had you had a statement simply in there that said, hey, the primary didn't sign this, we've asked 3 times, we mailed it to them, so we just used this registered nurse signature, that's fine. Okay, but that's part of those guidelines. And that's part of why we didn't even make it to the medical necessity for this one. So you can see, yes, medical necessity is important, and we've gone through a lot of that, but when we come down to the review, do we necessarily make it that far? And that's what these first few examples are trying to show. So nursing home to dialysis is our scenario 3. This is a scheduled routine transport with a PCS. So we want to make that clear. On there, it says that their patient is unable to stand and sit for more than 5 minutes. This is a complication due to diabetes and end-stage renal disease. The assessment shows the patient's having difficulty breathing, and they also have an open wound on the foot and back. Now, the open wound is what is the in the physician certification statement stating they can't put the pressure on it to sit for a long period of time. Standing comes from the foot. So this one was a little bit of a difference there. The transportation log has oxygen level adjustments and monitoring. Signature from the patient EMT leaving and receiving facility. Did we consider this one? Did we pay this one? Now this one we didn't pay, and we didn't pay it because the unique tracking number, the actual scheduled transport, they did go for a authorization, and that's fine. But when they did that, what they did is actually put a unique tracking number that was expired on the claim. So we looked at the claim and we went, okay, we can see where this one looks medically necessary. It looks like it should be payable, but that unique tracking number means you didn't do that and that it's not correct. Now that does leave them appeal rights and they could go back and look further into it, but we won't go that far until you ask us to do an appeal on it. Now I will let you know on it with everything else turned in. By the way, they did have the correct unique tracking number and they could have simply submitted the claim again. But with all of that said, this one did get paid. In the end, it just took a minute because of how the claim was originally submitted. Oops. This one, in the medical record, it said dispatch to obvious death. What medical record was that? It was the patient's EMT assessment. That was the opening line, dispatch to obvious death. Now, during the assessment, it says patient dead in recliner for a number of days. There was no transport. This is okay. It was billed with a BLS non-emergent, but no mileage code, and that's fine. The BLS was billed with a QL modifier. Again, that is correct. The CERT did the review on this one, and they took it back. They said due to the assessment statement that they were dispatched to an obvious death, they weren't expecting to find a person that was alive. Now, we don't really know what actually happened. We don't know if they were dispatched to a possible heart attack or whatever. The very clear statement was dispatched to obvious death, and due to that documentation, it was found to be something that Medicare would not consider. And scenario number 5. Why did we deny the EMT meets the nurse and verbally gathers information? The patient does have a chemical burn with breathing difficulties. They are a stable patient. They do need a higher level of care, treatment, and grafting. EMT assessed at the hospital. Patient transported to the airport for a fixed wing. Run report contains all the required information, but there's no PCS or attempts to obtain one. This one, it was deemed the patient was stable, that a PCS would have been needed because remember, they're going for grafting and other treatment at a higher level of care. The patient was not an immediate risk, so it was deemed that way for medical necessity upon the review. So medical necessity said you would have needed a PCS with this one of some sort. So even though you talked to the nurse, this one-time transport still should have had some form of a PCS. And the last scenario Okay. This one, there was no dispatch. And so the patient was found sitting on the side of the road, and they called it a load and go. They were transported to the ER. The ER denied for a second visit on the same day. The ER record shows they provided a sandwich and some juice. So the ambulance provider sent the ER record as proof that this was medically necessary. Well, first of all, the ER record would have occurred after the transport or before the transport. In this case, this was the ER record before the transport. They were already there. Remember, second visit. And the only thing that was wrong with that patient before the transport was, well, they needed a sandwich and some juice. Now, it doesn't state they were diabetic. It doesn't state anything like that. We just don't have enough information to really process this one as medically necessary. All right, which brings us to some questions and answers, and I'd like to go over these real quick. First one, does a 911 dispatch make a run medically necessary? The answer is no. Just because there's a 911 dispatch, it doesn't make it medically necessary. Keep in mind, it is the assessment. What did you see? What do you need? Okay. Next question, is weakness a valid reason for transport or for the incapability to sign authorization? No. Help us understand what weakness means. There has to be more information than just the patient's weak. And that's some of those generic statements that make it very hard for us to prove medical necessity. What do you do if the PCS doesn't accurately reflect what's in that patient care, that run report? Say it's bed confined, but they were walking to a cot. Whatever the PCS states, I still need you to document what actually happened. That documentation will be what we use more than the PCS. Again, we use the PCS to help support medical necessity, but the documentation about what occurred during the visit and the assessment is what actually makes it medically necessary. Couple of things, I was asked for a couple of appeals on possible tips for medical necessity appeals. One, on your appeal request, please be as specific as possible. Two, please be sure the reason for the request is what the claim was denied for. We can only look at what you're asking us for. Include all the signatures and the PCS. Include information the EMT would have had at the time of transport. A hospital destination, so I'm taking them to the hospital, I'm going to get a run report, or I'm going to get, discharge report from that destination. They didn't know that information. How could they get it? Make sure they know it. And lastly, please appeal the correct claim. We have quite a few appeals that come in and they're actually not listing the right claim number. I did have a comment, just zip codes. So let me just state, zip codes are not required for medical necessity at all. However, zip codes are required for correct payment. So you must have the point of disc code, or where you pick them up at, there, that zip code has to be on the claim. It does drive payment. For the CMS 1500, it's item 23 or the 837P segment on the electronic claim. For UB04, it's value code A0, so notice value code A0 and field locator 39 to 41, but you must complete that information as well with the zip code, and then you need loop 2300 segment HI. So again, zip code's not part of medical necessity, but it is going to be part of driving payment factor. Also, it can be used to help us determine facilities that are within a locality or where you would normally go. I was asked for some information on emergent versus non-emergent, and I just want to remind everyone, emergent versus non-emergent is not based in anything to do with what you find or your assessment. It's actually based in the protocol given in the time needed to get to the scene. This is actually from the Medicare Benefit Policy Manual, Chapter 10. So you want to make sure that you're aware of that, and the CMS Medicare Benefit Policy Manual is in the manual section on the CMS website. I did have a question on the golden hour rule for the data service. I'm not really sure exactly what you're referencing here, but I will say Medicare doesn't use any kind of rule like what you're referencing. Typically, a golden hour rule means within an hour of start of symptoms, an hour of care. None of that matters to Medicare. What we're looking at is when you got there and when you assess the patient, did they need your transport? How do you go about correcting the medical necessity if it's incorrect before a transport? I'm going to assume you're talking about incorrect in the documentation. So don't cross things out, don't move things, don't delete things. What you want to do is make an addendum and state, hey, we read through this paragraph. This is not the correct information. This is what it should be. And then who found the error, right? who entered the new information, and then why. What were they doing with it? So, what we're looking for is, again, the error that was found, why it was found, all of those types of things. When the sending hospital that orders the ambulance has different information, I think we talked about this one, versus what the crew arrives and sees. Again, remember, Medicare is going to hold the ambulance company liable. It's their crew that has to prove the medical necessity. So you can get whatever you get on the PCS or anywhere else. Okay, anywhere else. I do not have time to open for any questions, so unfortunately, I'm just going to keep going here. CMS resources are available to you. Again, I did mention the chapter 10, it's right here, and you're going to look at the definition section for what we were talked about there, and here are some other ones you might want to be aware of. Here's some resources from WPS. We do offer an ambulance documentation requirements checklist and other items that you want to be aware of. I'm sorry, the checklist is professionals ordering. The documentation requirements is an article. Clear that up. Checklist versus article. We do have some information on the repetitive scheduled non-emergent ambulance transports and the physician certification articles. So please make sure that you're, checking those out if you're interested. Wanted to let everyone know that along with that, if you use our interactive voice response system, we are going to discontinue the eligibility function on January 1st, 2025. This just simply means that you can't call and get eligibility. Instead, what you're going to have to do is log into our system, go in direct data entry, or use HETS transaction, the HIPAA eligibility standard transaction available through CMS. So we're not taking eligibility away. Just know that the IVR will stop giving it out on January 1st, 2025. Some resources and information there if you want anything on that. If you need a certificate of achievement and you did give me an email address, so when you logged in, it gave everything, you registered. If you didn't call in, essentially, call in are the only one that will not have this. Your certificate of achievement will be emailed to you shortly. If you do not have it by the end of today, please email us. And we've given you the email a couple of different times. I'm going to give it to you in just a second. Take the survey, but then the certificate of achievement is on that email and it's on the bottom. So keep that email. And you can see it's going to give you contact hours. That's what's going to be translated to CEU should your governing body choose to give those to you. Follow-up questions. I'm going to take follow-up questions for the next 7 days. Next Monday by noon, get follow-up questions, send those in to me. Please make sure that they are labeled accordingly. That means ambulance medical necessity webinar. They cannot get them to me if they can't figure out what webinar it's for, so please make you do that. If you do have something that's claim specific, it needs to go to customer service. Same thing with ResNet. If you have an authorization that's denied or anything else, I can't look at anything like that. You'll have to take those back to customer service. We talked about this briefly, but I want to remind everybody that you're going to be given the opportunity to take a survey. Again, in this survey, I want to, offer you guys the chance to provide the good, the bad, and the ugly. So tell me what I did well. Tell me what you thought of the slides, and tell me what I didn't do so good. What could I improve to make this training better for you? The good, the bad, and the ugly. A couple of ways you can do that. Link in the chat. You're going to get a box, including an external box, and you get pop-up. Also, it's going to come in that email. Any of those take you to the same survey, and you can provide the feedback. So I want to thank everybody for attending. Hope that you got what you needed out of it, and that we were able to answer all of your questions. If you did submit a question and I didn't get to it, I will come back to those and get that back to you in an email. So thanks for attending, everybody. On behalf of myself, Ellen, and all of Provider Outreach Education, we hope to hear back from you. We hope you get your feedback, and we hope to see you again in the future. Bye, everyone. You may now disconnect.